Welcome, everyone. This is David McConkey, and it's a great pleasure to welcome you to this talk today. Today, I have the privilege of introducing a close colleague and leader here at the GBCI, Jean Hoffman-Censits. She's very familiar to those of you who are active in the Bladder Cancer Advocacy Network. She's played a leadership role there for many years. And she, here at Hopkins, together with Noah Hahn, leads our clinical trials in more advanced disease. And like a lot of us, is very interested in immunotherapy. So not surprisingly, the topic of her talk today is clinical trials in immunotherapy. And just parenthetically, she is designing some very, very exciting clinical trials that integrate immunotherapy in novel ways that we hope to share with you more as the year evolves. So without further ado, thanks for joining us, and thank you, Jeannie, for giving this presentation.
Thanks, David, for the opportunity to give this talk, and thanks everyone for coming today. Want to make sure, Wasim, if you can see my slides as I scroll through.
Yes, I can see it.
Awesome. Okay. Thank you. Here are my disclosures for my personal research support and consultants. I want to start with a thank you. Sometimes we get so excited in talks that we skip past the thank you slide, so I started to put mine right in the beginning. This is our Johns Hopkins Greenberg Bladder Cancer Institute team with Mr. and Mrs. Greenberg, who are our generous benefactors, as well as Dr. McConkey, who you've met, and some of our other team members, Noah Hahn, Trinity Bevilacqua, and a multidisciplinary group of physicians, scientists that include radiologists, pathologists, radiation oncologists, basic scientists, all a growing number of investigators all interested in urothelial cancer, making this such a great and exciting place to come to work every day. So cancer of the bladder and urothelial cancer in general is a common problem, and as many of you know, you didn't know it was common until either you or someone that you loved were diagnosed with urothelial cancer. In men, it's the 4th most common cause of cancer. And when we talk about bladder cancer, really talking about this group, this urothelial cancer, the most common kind of bladder cancer. So as we look under the microscope, the urothelium is the normal tissue that we find in the bladder. And so when that tissue becomes mutated and changes into a cancer, it changes into urothelial cancer. And sometimes patients will ask, well, if it's moved to my liver, don't I have liver cancer? And in fact, no, it's urothelial cancer that's moved into the liver. So we treat it the same way. There's other kinds of bladder cancer and tumors that we also find in the upper tract. Less common, squamous cell adenocarcinoma and small cell, which is one that we're particularly interested in. And these are not so common and also not as much known about how to best treat those cancers. So it's one of our interests here at the GBCI. So who gets bladder cancer? So the average age of patients that come to our office that have bladder cancer is about 73. It's a male predominant disease, and a lot of patients have a history of smoking. It does not mean that it's someone's fault that they got bladder cancer, but we do know that there's some things that put people at risk for having bladder cancer, and that can include a history of smoking. But we have plenty of patients who are non-smokers who are coming to our clinic as well. Having certain exposures, like industrial exposures, dry cleaning industry, trucking, dyeing and manufacturing industries, and then compounded with smoking, can put people at higher risk. And then of course, some genetic causes and family history of bladder cancer can put patients at higher risk. But because we're a large bladder cancer center, we don't just see the patients that are the most common. We see patients all across the age spectrum. We see patients across different races, as well as men and women. Even though women don't get bladder cancer as often as men get bladder cancer, when they do get the disease, it tends to be diagnosed at a later stage, and partially because of that, they can have a worse prognosis. So again, this is of particular interest in ours at the GBCI. Because patients have a history of smoking, or often have a history of smoking, and they're older, they also come to us with other medical issues, and those are called medical comorbidities. And they can include things like hearing loss, changes in their kidney function, either from other diseases like diabetes and hypertension, or from the cancer itself, which can block the plumbing of the kidneys, called the ureters. They can have cardiovascular issues, peripheral neuropathy, which is numbness and tingling in the fingers and toes, and an altered functional status, which means their ability to get up and go, move through their daily life, whether or not that includes working at a job or not, taking care of home, or taking care of themselves. Because our treatments have various degrees of toxicity, we have to think about all of these different comorbidities, or what a patient brings with them with their cancer diagnosis, for us to individualize and make appropriate treatment decisions. So when we think about normal urothelium, when we look at the tissue under the microscope, or when actually our pathology colleagues look at tissue under the microscope, normal urothelium, or the inside lining of the bladder wall, is this very regular appearing wall. It's 7 layers thick, and it looks like a brick wall that you would build right outside of your home. Patients that have a low-grade bladder cancer, and that's what this looks like under the microscope, have this kind of papillary or frond-like appearance of the tumor that goes into the big muscular balloon of the bladder. And a low-grade tumor, these are tumors that the way that they act is they tend to come back over and over again and be scraped out by a urologist with a procedure called a TURBT, or transurethral resection of the bladder tumor. And they look somewhat disorganized compared to what normal urothelium, of the normal inside lining of the bladder, looks like. A high-grade tumor is a much more disorganized tumor and can invade into normal adjacent structures. So if we look here, this is this is where the urine would be on the inside of the bladder wall. This is the tumor here, and then this is kind of normal tissue. This is a high-grade, this is a low-grade tumor, and then over here, this is a high-grade tumor. You can see it's very kind of discohesive and disorganized. And this tumor is already invaded into local structures. So when all the different doctors, the clinical team here at the GBCI, when we meet a patient, we think about, and when they get sent to different doctors as a new patient, or referred to different doctors as a new patient, that's in part really based on where the tumor is. So for the most part, urologists are the ones that lead the charge in patients that have non-muscle invasive bladder cancer. So if we take a line right here, and again, this is a schema of the inside lining of the bladder wall. So if we take this big muscular balloon that is the bladder, and we just take a section right like this and lay it down flat, that's what it looks like. The top layer, which is this inside layer here, is called the laminar propria. And then we have 2 muscle layers. And really this muscle layer is the line in the sand, determining whether or not a patient will have multimodality therapy that can include surgery, chemotherapy, and or radiation, or whether or not potentially the tumor is amenable to topical therapy alone with local surgery with a TURBT. And that's here if it's just locally invasive into the bladder. So if you hear those terms, muscle invasive bladder cancer or non-muscle invasive bladder cancer, that's where these terms come from this line here. As you can see, these tumors can grow roots and can grow into the muscle layer of the bladder. So these tumors here, carcinoma in situ, as well as these non-muscle invasive tumors are here, and then the muscle invasive tumors can grow more deeply into the bladder wall as well as onto adjacent structures. So what are the tools that we use, and how do we how do we think about treatment of bladder cancers no matter where they are? So when you think about the pillars of cancer therapy, not just the tools that I use, but kind of what do we use in general? And this is true across the board for many cancers. There's surgery, there's radiation therapy, there's chemotherapy, and then there's more modern novel therapies called targeted therapy and immunotherapy. And I'll introduce all of those to you and give you some examples of what we're using here in the GBCI and in bladder cancer in general. So chemotherapy, and I want to preference the next couple of slides. I have a reference down here. A lot of these come from a website called cancer.net, which is from the American Society of Clinical Oncology. They have a great website that discusses a lot of kind of patient-centered issues, focusing around things like clinical trials and answering many great questions about clinical trials. So a lot of these next slides are lifted from that website, but I have the directions to get them here. So chemotherapy uses drugs to destroy cancer cells. These chemotherapy drugs, they're usually quite old in terms of how long they've been around and how long they've been FDA approved, but they can keep cancer cells from growing, dividing, and making more cells. Because cancer cells grow and divide faster than normal cells, chemotherapy can have more of an effect on cancer cells. But those of you who I've seen in clinic, you know that I call chemotherapy a big stupid hammer. So it doesn't necessarily, when we give chemotherapy, the chemo doesn't necessarily know what's a normal cell and what's a cancer cell. And the person that has the cancer has to put up with the toxicity of the chemotherapy, because our own healthy cells are also affected by this medication. And that's why when our patients have chemotherapy, particularly the chemotherapies that we give pre or post surgery to remove the bladder or the kidney for urothelial cancer, they will have a hair loss and hearing changes and peripheral neuropathy and something called mucositis, or sores inside the mouth, nausea and vomiting, as well as changes in the blood counts that can be transient but put people at risk for serious or life-threatening infection. And so, you know, clearly thinking about other modalities of treatment that may be as effective as chemotherapy but potentially less toxic are certainly important. And this is also important in the context of what I said earlier, in that, you know, the average age of patients that come to our clinic with bladder cancer is 73 years old. And a lot of those patients have other medical issues and may not be candidates to get what is the current standard of care, which is chemotherapy. So what about targeted therapy? So how does targeted therapy work and what is it? So targeted therapy really is better understanding what makes a cancer cell tick. So what's the difference between a cancer cell and the cells that are living right next to it that are completely within normal limits? And you know, when Dr. Bevilacqua or Dr. Perazio or Dr. Cates or Dr. Smith, when they do TURBTs, we can see under the microscope that there are disease cells, cancer cells, right next to normal tissue. So what's the difference between those two? And in part, we know that normal cells can transform or change, or they can mutate, and those mutations can then cause cancers, can then cause normal cells to grow more quickly. And they can also not follow the regular rules that all cells have. So just like that 7-layer thick brick wall that I showed you earlier, well, that brick wall, the urothelium, you know, those cells are interacting with each other and they're following certain guidelines. They only live for a certain period of time. They're not really supposed to break into their neighbor's house. They're not supposed to dig or move. They're not supposed to dig, you know, into the foundation of their house or, you know, invade. They're not supposed to go to a completely different neighborhood or metastasize. But cancer cells develop changes or mutations that allow them to do all those different things. And so by understanding at a molecular level the difference between a disease cell and a normal cell, and then utilizing that information has helped us develop targeted therapy, not just for bladder cancer, but for many different kinds of cancers. And the way that we do this is in part individualizing that therapy. And this is actually one of the ways that I kind of think about this. So when I say that we have a normal cell next to an abnormal cell, one way to think about this is a car full of kind of crazy people or, you know, interesting characters that are all kind of different than what would normally be expected. And when we get a report, which I'll show you just in a second, of what are these genetic changes or alterations, we may have a list of things that are different about a cancer cell compared to a normal cell. But even though these are possible targets or possible alterations that we can find a medication that maybe might shut down a certain pathway, it's important also to know, well, what is the driver? You know, what is the actual mutation or the lead mutation that might be generating the cancer cell to kind of move into change? And at least in urothelial cancer, we do know that there are some that are more likely than others to be responsible for a cancer cell transforming and growing more quickly. This is an example of one of several platforms that are commercially available as well as available in other settings to understand what those mutations or changes are. So currently in urothelial cancer, it is standard of care for Dr. Hahn or I or other doctors that take care of advanced bladder cancer patients for a living to order what's called a next generation sequencing test. And when we get these reports back, this is just an example of what this looks like. So we can see that on this report, it comes back that there are these genes that are altered. Sometimes it tells us that they're altered, and we understand that that alteration has already been reported as a change or an alteration that is a known driver mutation that can lead to urothelial cancer, and sometimes not, that it's just what we call a mutation of uncertain significance. These things are different than normal cells, but we're not quite sure what that means. And on this report, it's important to see this one, FGFR3. This is mutated or pathogenic in this patient, which means that we could potentially use a targeted therapy that is FDA approved for urothelial cancer. That's called erdafitinib or Balversa, and we'll talk about that medication in a couple of minutes. And then finally, we have immunotherapy or systemic immunotherapy. Again, as many of you know, I give the example of President Jimmy Carter, who has melanoma and was treated with immunotherapy and has done quite well. So, you know, what is immunotherapy and how exactly does it work? So, you know, we are born with all of our organs, our skin, our bones, our liver, our kidneys, and we're also born with our immune system. And that immune system, part of its job is to learn about different threats that come from the outside, different infections like viral infections and bacterial infections, recognize those infections, develop an attack system or antibodies against those organisms. So hopefully we will not get infected with the same organisms over and over again. And that's kind of called the gas pedal. And at the same time, the immune system develops a brake pedal, which means that it is constantly surveying our own body and recognizing, you know, what is our own skin, what are our own kidneys, what are our joints, what does our liver look like, with the goal of balancing, attacking things that are foreign as well as protecting things that are self or preventing autoimmunity, things like lupus, rheumatoid arthritis. That's a really delicate balance. At the same time, our immune system is supposed to survey or be aware of these cells that can change or can mutate and turn into cancers. And when it finds those cells, because they look so strange or different, attack and kill those cells. So what happens with this pathway and the way that cells can interact with each other are by, it's almost like a lock and key mechanism called a receptor and a ligand. So these receptors and ligands can interact with each other, and immune cells can kind of recognize that interaction and use it or upregulate this normal interaction system, even though they mutate and change. The immune system for some cancers and for some urothelial cancers can recognize that there's something not quite right about these tumor cells. But because they have kind of the right cloak on or the right clothing on with this PD-1, PD-L1 communication system, the immune cells don't attack the tumor, but may just kind of sit near it or next to it, recognize that it's not normal, and then sit there and not attack it. So what all these different FDA-approved medications do, PD-1 inhibitors include pembrolizumab, nivolumab, and PD-L1 inhibitors, atezolizumab, avelumab, and durvalumab, and that's really based on kind of which side of the street these drugs interact with or sit on. What these drugs do is just interfere with that interaction so the immune system can recognize that there's a foreign cell there and attack it. And again, the immune system, cells within the immune system might be sitting right next to those cancer cells just poised to attack. This is a picture of Jim Allison. Jim Allison is spent the bulk of his career, I think the first part of his career in isolation, studying the immune system and cancer, and now has won the Nobel Prize for discovering and developing drugs along this pathway. And this is important because this isn't just important for urothelial cancer. As of the publication of this paper, which I think was in May of 2020, checkpoint inhibitors, which they're called, these PD-1, PD-L1, as well as CTLA-4 inhibitors, are FDA approved for multiple different cancer types in multiple different settings. And in fact, the settings for urothelial cancer are not even up to date as of the May 2020 publication of this paper. But FDA approved for squamous cell head and neck cancer, melanoma, Merkel cell carcinoma, squamous cell carcinoma, liver cancer, renal cell carcinoma, something called MSI high or DDMMR cancers. So this is the first FDA approval that's across cancer types. So if there's certain molecular alterations that we see within any tumor, those patients can be treated with immunotherapy. Cervical cancer, multiple different kinds of lung cancer, breast cancer, gastric cancer, Hodgkin's lymphoma, a central kind of lymphoma, as well as urothelial cancer. So we keep talking about clinical trials, and I think as doctors we talk about them a lot, but don't maybe spend the time that we could on defining what these are to make sure that everyone understands what it is that we're talking about. So what is a clinical trial? And again, all of this information is coming from the cancer.net primer on clinical trials for patients. So clinical trials are the main way that doctors find better treatments and learn how to prevent disease or treat symptoms and side effects. And all these clinical trials are actually mandated by the FDA. So it's important to know that the things that we're doing are in regulation with this government agency, as well as European agencies that have similar mechanisms. What types of clinical trials are there? So there's clinical trials for new kinds of treatments. There's clinical trials looking for treatments for different side effects and symptoms, looking for long-term side effects to prevent and look for cancer. The rationale for different clinical trials can really be endless. So we talk about clinical trials in different phases. There's a phase 1, phase 2, as well as phase 3 clinical trials. So what do we mean when we use these terms? So phase 1 clinical trials are to learn if a new drug, a treatment, or a combination of treatments, one of which may be, or two of which may be FDA approved but never put together before, is safe for people. These agents may or may not have previously been tested in laboratory animals. And important information is collected on, one, the dose. What is the best dose for treatment? And in fact, even though we are looking at efficacy or how well a phase 1 clinical trial may control a cancer or may control other diseases, because these clinical trial types span across different diseases, including diabetes and hypertension and heart disease, we're looking for what's called the maximum tolerated dose, or what in general is the dose that most patients are able to tolerate without significant toxicity. When are you supposed to take it, and how often do you take it with food or not? And in part, they may involve multiple blood draws called PKs, where we try and get blood levels of the drugs. Are there any side effects or problems? In particular, the FDA looks at EKG changes as well as liver function changes during this period of time. How the treatments affect you and how it can affect the cancer as well as side effects. Participants in phase 1 clinical trials may be the first people ever to be treated with these medications. And they tend to be rather small. Sometimes they're at very few centers, sometimes they're at a few more, but in general, they tend to be small and very tightly regulated with a certain number of patients, even as low as 3 or 4 or 6, moving through one dose level at a time. And not until a certain amount of time has passed, or each of those 6 patients safely make it through dose level 1, do you then escalate or move to a higher dose level. In phase 2 clinical trials, if a drug moves from phase 1 into phase 2, let's say a brand new drug, Often the dose for the phase 2 clinical trial, which is a larger study, comes from the recommended dose or the maximum tolerated dose from phase 1 clinical trials. So these are generally run with a larger amount of patients, about 25 to 100 patients, and tell us more about the safety and efficacy of novel drugs or novel combinations. These trials can last a longer period of time, up to 2 years. Sometimes they're single arm studies, which means we're just looking at one drug in isolation. Sometimes they're randomized studies, which means that there's 2 different groups, maybe getting a different dose of the drug or maybe getting a different combination of the drug. And then finally, phase 3 clinical trials. So these are the very large clinical trials, which often kind of define or change the standard of care. If there is no current standard of care, a drug may be fast-tracked or FDA approved based on a smaller phase 2 clinical trial, and that has certainly happened in bladder cancer. But most changes in standard of care will go through one of these larger, multi-year, thousands of patients, oftentimes international phase 3 clinical trials. So the goal of these is to compare a new treatment with the standard treatment to determine if the new treatment is better, has fewer side effects, or both. So if and when there is a placebo in a clinical trial, it may be in a phase 3, or if and when there is a randomization to no treatment, if that is the current standard of care, that may be in a phase 3 clinical trial. This will absolutely include men, women, people of different ages and ethnic groups, if possible, with the goal of getting a really heterogeneous understanding of how new drugs work, and to determine how these drugs work and whether or not they are better in terms of efficacy and or toxicity than the current standard of care. If they are, then a new standard can be established. And this is just a pictorial view of what's called a preclinical evaluation. So the clinical trials don't kind of start in isolation. It takes oftentimes many years, sometimes even decades of thought and understanding and really better understanding the biology of a disease, and then working towards a clinical trial that then will often start in a phase 1 or a phase 2 and then open it into larger clinical trials. A phase 4 study is after a drug is FDA approved. If there is not a really large cohort of patients that were initially tested in clinical trials, say it's in the phase 2 setting where there is no current standard of care, then the FDA may allow a drug to go through for patients in general to receive that drug, but they will continue close monitoring of all patients getting a standard drug, and then kind of use that data in a prospective fashion to better understand toxicity and efficacy of agents. And how do we know how to find these clinical trials, or how do patients know how to find these clinical trials? So, here at the Greenberg Bladder Cancer Institute, we have a list of clinical trials that Dr. Hahn and I, as well as our radiation oncologists and our urologists and others, have either designed and developed here at Hopkins or on a national level, or have agreed to participate in an industry-sponsored or what's called a cooperative group study. So there's kind of different sponsors for different clinical trials, but the number of ongoing clinical trials is really dizzying. And in fact, if you go to a publicly available database, which I have here for you, it's called clinicaltrials.gov, and you just type in bladder cancer clinical trials, there's 1,229 studies that have been found for bladder cancer. So this website can be queried looking for active clinical trials, open clinical trials. And if you have kind of worked with one of us in terms of finding a specific clinical trial to meet a need that potentially may not be available here, because not one center can always have clinical trials for every single person in every single what's called disease site, then we can manipulate the data in we can query the data in this publicly available website and find open clinical trials. So let's talk about where we are in terms of FDA approvals for urothelial cancer. And this is a timeline I put together. It's really not kind of chronologically accurate, given that so many dates are smushed together. But as you can see, there's been a lot that has gone on in the past 4 years. So cisplatin was FDA approved in 1978, and I'm not going to tell you how young I was in 1978, but definitely not young enough to be a doctor or in high school. And then nothing happened. There were no new approvals until 2016, and that's when the standard of care, which is still cisplatin-based chemotherapy, either in the preoperative setting before a nephroureterectomy or cystectomy for bladder or upper tract cancer, or for the first-line treatment of metastatic urothelial cancer. After that, even though there are drugs that may be helpful, none of them were kind of put into our guidelines saying these are definitely medications that can improve not only lifespan, but quality of life. And all that changed in 2016. So a few years before, one of the other immunotherapy drugs called ipilimumab, which is a CTLA-4 inhibitor, was FDA approved, I believe, in 2010 for melanoma. And things really changed after that, with really understanding that the mechanism of how that drug worked in melanoma could be translated to all different cancers. And urothelial cancer was one of the first that was studied because, number one, it had a high what's called tumor mutation burden, which means that the number of mutations or changes or kind of how different the bladder cancer cells are when they're mutated and cancerous look very different to the immune system than normal cancer cells. The more different cancer looks to the immune system than normal, the more likely it is to respond to immunotherapy. So that was one of the reasons that a lot of pharmaceutical companies started to investigate bladder cancer as a target for immunotherapy. And the second is that when the landscape was pretty empty, that there were no therapies approved past one chemotherapy cocktail, then there was plenty of room for improvement to save lives in bladder cancer. And so we're grateful for that interest and the changes that have happened since. So atezolizumab was the first approved in May of 2016. And this is for the second line or beyond, meaning having had platinum chemotherapy or later. The same with nivolumab a year later. Atezolizumab was approved in April of 17. Pembrolizumab was approved for the first line treatment in patients who could not get chemotherapy or platinum-based chemotherapy, as well as durvalumab and avelumab. Atezolizumab was approved for the first line, same if you could not get chemotherapy. In August of 2018, we learned a little bit more about how to use atezolizumab and pembrolizumab in the front line, and I'll talk about that in a few minutes. A targeted therapy called erdafitinib was approved in April of 2019 for FGFR alterations. An antibody drug conjugate called enfortumab vedotin was FDA approved in December of 2019 for patients that had both platinum and immunotherapy. Pembrolizumab for BCG unresponsive non-muscle invasive bladder cancer was approved in 2020, and I have that in green for non-muscle invasive disease. Mitogel was approved in April of 2020 for low-grade upper tract urothelial cancer. And then finally, the immunotherapy called avelumab had a widened indication for maintenance therapy in urothelial cancer. And every single one of these treatments, everything we know about the treatment of bladder cancer and about these novel therapies are based on hundreds and thousands of patients in each of these clinical trials who agreed to sign on to a clinical trial, who agreed in part to start a medication like atezolizumab that had never been tested in bladder cancer before, and to be brave enough to be part of one of these studies that have changed standard of care. What we don't have on here is all the clinical trials that did not either currently yet or in the past become standard of care, but it's overwhelming to think about all of the work and all of the input and all of the different components and people behind the success of these studies that have brought these novel therapies to our patients to become standard of care. And not only the patients, but family members. We know that this all comes with groups of people who drive and who take people to their laboratory studies and pick up medications and do all the amazing things they do. So it's really overwhelming to think of all of the work and all of the energy and love that has gone into changing the standard of care and doing so incredibly rapidly. So I'm going to switch gears for a second and talk about upper tract urothelial cancer. So a lot of the time we talk about tumor here in the bladder, but urothelial cancer can happen here in the ureters, which connect the kidneys to the bladder, as well as kind of this little reservoir you can't see here called the renal pelvis. It's about 5 to 10% of all urothelial cancers. Patients tend to be a little bit younger if they present with upper tract urothelial cancer, and the tumor can come back either within the system itself, if it's a low-grade tumor, or into the other side and also into the bladder. The standard of care is to completely remove the renal unit as well as the ureter, which of course then can potentially put somebody at risk for renal insufficiency. So one of the things that we're really proud about is here at the GBCI is this website. I think our website is quite good, but one of the things that we've added is this page to describe upper tract urothelial cancer. This is a very rare disease. And when patients are diagnosed with this very rare disease, again, like bladder cancer, but probably even more so, they are unlikely to ever have heard about it or anyone else that they would discuss their diagnosis with. So we wanted to have a safe web presence where patients and families could go to get information about this, as well as a 3-minute video that we put together. This is Dr. Phil Perazio, who's a surgeon in our urology division, who's the narrator of this 3-minute, really informative video. And so we are hopeful that this information has been useful for our patients and families. And as Dr. McConkey said, also shared with our partners at the Bladder Cancer Advocacy Network. You can find this on their website as well. We have a core group, Dr. Perazio and I, who are interested in the treatment of upper tract urothelial cancer, as well as a new recruit, Dr. Nirmish Singla and Andres Matoso from the Department of Pathology. We're working to put together what's called a multidisciplinary clinic to evaluate patients with upper tract urothelial cancer in real time with multiple different subspecialties. That wish has been curbside a little bit by COVID, but we're working to make that a reality. One of the things that we're really excited about is this trial, which is now become standard of care. As I said, the treatment for upper tract urothelial cancer is to completely take out the kidney, but that leads patients with another comorbidity because taking out a kidney will often lead to kidney dysfunction. So this is an important treatment, again, FDA approved in 2020 for low-grade upper tract urothelial cancer. And what this is a topical installation of a local chemotherapy. So many of you on the call may have had or have a family member who may have had BCG or a local immunotherapy that bathes the inside of the bladder for a non-muscle invasive bladder cancer. It's much harder to get a local therapy into the ureter or the renal pelvis and to have it actually stay there. You may be able to temporarily bathe that area, but to have it kind of stick is nearly impossible unless there's a company that comes up with this very interesting polymer that's solid at body temperature and liquid at low temperature that can be injected into the upper tract during a cystoscopy and then can dwell there for a certain period of time. And in that polymer is embedded chemotherapy with the goal of treating that lower tract cancer. So based on 71 patients in this phase 2 clinical trial that were treated, that there is evidence that 89% were disease-free at 6 months, which is really important. So the idea that a local therapy that can be done in a urologist's office or in an operating room can potentially delay, defer, or completely eliminate the need to maybe remove a kidney in someone who has low-grade upper tract disease is a really important development. And so we're pleased to be able to offer this to our patients. Since this drug was FDA approved in 2020 and is a multi-step process that includes a procedure. This is not so widely available, but becoming more commonly available. We know that cisplatin is, like I said, the standard of care for patients who have bladder cancer, as well as a standard treatment for patients who have upper tract urothelial cancer. And we know that since this medication is metabolized by as well as toxic to the kidneys, that the ability or the candidacy for someone to safely receive this medication can decrease before and after the standard surgery, a nephroureterectomy, the patients will get for a high-grade upper tract urothelial cancer. And because of that, we have developed a follow-up clinical trial to a study that we've done previously. This is a large-scale randomized phase 3 clinical trial that is in late stage of development. So I mentioned kind of different mechanisms by which clinical trials will come to different cancer centers. And this mechanism is through something called the cooperative group mechanism, meaning that these are ideas that are started by clinical investigators like me, like Dr. Hahn and others. And we bring it through the National Cancer Institute as well as multiple other national governing bodies with the hope that a clinical trial can be done at multiple different cancer centers at a reasonably low cost using standard and novel treatments. And with the goal of this clinical trial is to use standard chemotherapy with or without immunotherapy to determine if that platform is better or worse or the same than chemotherapy alone in patients with upper tract urothelial cancer who go on to have a nephroureterectomy. So more to come with that. And again, this is based on a clinical trial that we previously completed with the same mechanism here at Hopkins and across the country. So in the adjuvant or in the post-operative setting, there are several clinical trials ongoing. Currently, the standard of care if someone had pre-operative chemotherapy for either muscle-invasive bladder cancer or high-grade upper tract urothelial cancer, the current standard of care is just observation alone. And we know that for patients that have advanced tumors that were refractory to chemotherapy, so if I gave chemotherapy and Dr. Bibalacqua took out someone's bladder after that chemotherapy and they had viable disease in a lymph node, well, that's certainly a patient that we are concerned that the cancer could recur or come back into other lymph nodes or into other organs, compared to someone where maybe the cancer was completely annihilated by the chemotherapy. So in a space where the standard of care is just observation or just nothing, that's a space where we know that we could potentially improve standard of care by using novel medications. So this clinical trial, which we're bringing to Johns Hopkins, this is a national clinical trial looking at a targeted therapy. This is a randomized phase 3 study of a treatment infigratinib, which is a targeted therapy against FGFR3 in patients whose tumors express that target versus placebo. And this is an ethical study because the placebo is the current standard of care. So this is what it's being compared by, looking at different endpoints, including overall survival and disease-free survival. There's also several different clinical trials ongoing with this schema looking at the same population of patients who had preoperative chemotherapy and surgery and still have a high-grade tumor, or for patients who couldn't get preoperative chemotherapy because of kidney function or other comorbidities, looking at post-operative FDA-approved pembrolizumab. So that even though pembrolizumab is FDA-approved, it's not approved for post-operative therapy. So we don't know whether or not it works in that setting. And that's why this clinical trial and several others like it are ongoing. Other clinical trials that we have in development are ones looking at retaining kidneys. So some of our patients only have one kidney but have urothelial cancer. So we're looking to see if systemic therapy might help those patients. Understanding predictors of treatment response. So what alterations, what changes may predict sensitivity to chemotherapy and help us appropriately choose the right patients for the right therapy at the right time. Really understanding how platinum and other agents are toxic to the kidney since the kidney is coming out. What can we learn about the native kidney that's not diseased, about how these drugs work, as well as a really pretty robust imaging department here at Johns Hopkins and how we can use imaging to better understand these diseases. In non-muscle invasive bladder cancer, we have quite a few trials ongoing. I want to highlight two that are investigator-initiated trials, which means that Dr. Hahn, as well as some of the scientific team here together over the course of several years, designed, developed, and put these clinical trials into action. So this ADAPT clinical trial is a really interesting, very complicated trial. And in part, I think Dr. Hahn named it ADAPT so it could change with time, looking at immunotherapy called durvalumab plus topical immunotherapy that goes into the bladder called BCG, with or without other kinds of modalities of treatment. And this includes patients that have BCG unresponsive tumors, as well as BCG relapsing tumors. So this trial is ongoing and getting through different phases of the study. This is another trial looking at a systemic therapy with a drug called pemigatinib, which is an FGFR inhibitor. So a treatment that someone can take with the goal of seeing if that can lead to an impact on their non-muscle invasive bladder cancer. So this is enrolling patients with prior low or intermediate risk non-muscle invasive bladder cancer who on the surveillance cystoscopy, when the doctor goes back to take a look inside the bladder, winds up having a recurrent urothelial cancer. So this is really a novel platform looking at that systemic therapy in that disease state. This is a national trial looking at chemotherapy, which is standard of care, plus radiotherapy for certain patients with muscle invasive bladder cancer. So for patients who may potentially not be eligible for surgery for their bladder cancer, or who have a specific set of criteria that make them a good candidate based on their tumor location and characteristics. Looking at the standard combining chemotherapy plus radiotherapy together for a 6-week course, or combining chemotherapy together with radiotherapy and adding immunotherapy. So again, using a standard FDA-approved medication at a standard dose and schedule, but using it in a novel, what's called disease state. So we don't know whether or not adding immunotherapy to chemotherapy and radiation will be better, worse, or the same than just doing chemotherapy and radiation alone. And we need to understand also the side effects of therapy. So even if adding immunotherapy might be significantly better, if the side effects are 2 to 3 times worse, then the cost for that benefit is too much, and this would not become standard of care. This is a large randomized phase 3 study. So we're going to spend the last few minutes talking about advanced urothelial cancer and the evolution of standard of care. So again, when I decided as a young investigator to kind of devote my career to taking care of bladder cancer and urothelial cancer, it was in part because of this slide. So up until the spring of 2016, if someone had a metastatic or advanced urothelial cancer and received cisplatin-based chemotherapy, there was really nothing else that we had to offer. And so this is why clinical trials are so important, because you saw that timeline that now has so many different drugs that are FDA approved in this space. And again, all the different advances that have been made across the country and the world in this community of doctors and researchers that think about this disease. So in what's called the first line, meaning if someone has a metastatic disease and they're being treated with their first kind of therapy, we're looking at patients who are either eligible or ineligible to receive chemotherapy. Some of our patients are very frail and potentially much older, in their late 80s or 90s, and we think that may not be a good candidate to receive systemic chemotherapy. For those patients, immunotherapy may be a good option that may be well tolerated and also lead to a benefit. We know that in untreated patients, the rate of shrinkage can be as high as 20 to 25%, with a melting rate or a durable control rate that's as high as 9%. So those are important numbers. For patients that are eligible to receive chemotherapy, The first line is chemotherapy, and we know that at least for some patients, chemotherapy is probably a better first treatment than immunotherapy if you're chemotherapy eligible. And if the tumor grows or progresses, we use immunotherapy. Those standards are potentially changing, are actually changing pretty soon. We also know that if a tumor has a high expression of PD-L1, that immunotherapy may be a good first choice for those patients. This is an FDA-approved agent for urothelial cancer called erdafitinib. So again, on that sequencing report, if a tumor has an FGFR3 alteration, we know that if a tumor progresses on first-line chemotherapy, that this is a medication that can be used. This is a pill treatment for patients. So for those who are used to being in the infusion room and getting treatments on a regular basis, this is quite a diversion from that. This is called a waterfall plot. So a waterfall plot, the way that we look at this is for patients, so these lines are individual patients, and the lines represent what's called a tumor burden. So if someone has 3 lung lesions that a radiologist is measuring, and they're each 1.5 centimeters, they put that entire size together and then determine if at baseline and then following several cycles of therapy or a certain time on therapy, that tumor is shrunken down in aggregate, doing all the measurements together. Did it stay around the same size or did it grow? And if a tumor shrinks down by 30% or more, that's labeled a response. So when you see us talking about response rates, it means that the tumor has shrunk down a certain level. If you're on this waterfall plot as an individual patient and you're below 0, that means the tumor is shrinking. Above, that means the tumor is growing. So as you can see with this waterfall plot, that there's more patients where their tumor aggregate got smaller compared to bigger. And even though some didn't get smaller than 30% smaller, some of them completely disappeared at almost 100%. And in aggregate, the response rate was 40%. So this is an important tool that we have in our toolbox. It does have some unique, what's called on-target toxicities. So tumor cells are not the only thing that express FGFR3, and we know that can be expressed in skin cells. There's ocular toxicity, there's nail toxicity, as well as a unique side effect called hyperphosphatemia, or an elevated phosphorus level. And we know, at least with one drug in this class, that an elevated phosphorus level seems to correlate with efficacy, or how well the drug works. So after that drug was approved, if a tumor has an FGFR mutation or fusion, then we have erdafitinib in our toolkit. Enfortumab vedotin was FDA approved in December of 2019. This early clinical trial was in part run here at Johns Hopkins with my partner, Dr. Noah Hahn. This is a very unique class of medications. It's called an antibody drug conjugate. And again, for those of you who've talked to me about this in clinic, I call it a smart bomb. So instead of kind of old, stupid chemotherapy that beats everything with a hammer, enfortumab vedotin and other antibody drug conjugates are an encapsulated chemotherapy attached to essentially a warhead that's able to seek out and find cancer cells, inject that chemotherapy into the cell, and then kind of explode the cancer cell where it is. That leads to improved efficacy and decreased toxicity. So really kind of cool mechanism of how this drug is built. Another waterfall plot, which shows, again, more patients whose tumor in aggregate got smaller with several cycles of enfortumab vedotin versus those that got bigger with time. The response rate for this drug was 44%, and including some patients that had complete disappearance of their tumor. Like all drugs that we use to treat cancer, this drug has side effects that can include things like skin changes and numbness and tingling in the fingers and toes, and unique rashes. We just got a press release, actually, that another cohort of patients also that were tested and were participating in clinical trial here at Hopkins, patients who were too frail to receive cisplatin or carboplatin-based chemotherapy and went on to receive first-line checkpoint inhibitor, either with pembrolizumab or atezolizumab, were able to enroll to a trial with enfortumab vedotin at the time of disease progression. We don't have the complete data yet, but we do know that a public press release came out yesterday that again showed in this population of patients, this seems like an effective strategy. And so since the drug is FDA approved, what we would expect at some point in the future, after the FDA has the opportunity to look at all the data, that the indication for this drug will be expanded. So the drug is already approved for platinum and immunotherapy refractory urothelial cancer. We expect at some point this will be expanded. And so now, as of December of 2019, enfortumab is FDA approved. Whether or not a tumor has an FGFR mutation or fusion, as far as we know, this doesn't seem to impact whether or not a tumor would respond, but more to be learned. We had an exciting change in urothelial cancer that was reported in New England Journal of Medicine, so you know it's pretty exciting, in September of 2020. So the results of this randomized phase 3 clinical trial that happened across different countries in 700 patients, half were randomized to receive an immunotherapy drug called avelumab, FDA approved for advanced urothelial cancer, but instead of giving it, if a cancer progressed after platinum-based chemotherapy, the way that the investigators gave it in this setting was if someone came to our office and had metastatic urothelial cancer, they would get first-line chemotherapy, and as long as the cancer was either shrinking down or at least stable, for those patients that met those criteria, they were randomized. Half went straight on to immunotherapy with avelumab, and the other half were followed. And what happened with this clinical trial is that the median overall survival, or how long people lived, was improved if you immediately started immunotherapy rather than waiting for the cancer to progress. And that was true across the entire population, as well as those patients that had the target for avelumab, which is PD-L1. And because of that, avelumab is now FDA approved following immunotherapy. So much, as you can see on the slide, has changed in the last few years. Just going to end with a few final slides talking about key phase 3 trials looking at frontline therapy, which again may be changing. So in many other cancers, particularly those that have a lot more kind of patients that are affected by cancer, particularly lung cancer, they have similar clinical trials ongoing, and some of these clinical trials have completed their accrual. And we know that in lung cancer, combining immunotherapy with chemotherapy together is an effective, safe strategy. And so the same clinical trials are being done in bladder cancer. What is better, immunotherapy alone, immunotherapy plus chemotherapy, or chemotherapy? So that's the design of several randomized phase 3 clinical trials. Some of these are starting to read out at this point. There's 2 that look like they're negative, which means it doesn't seem to benefit patients if they have combination therapy early on, and potentially that sequencing chemotherapy immediately followed by immunotherapy might be better. Although there's one that looks like it may wind up being positive. This was an early report from this clinical trial, randomizing patients to treatment with all 3 drugs, a drug called atezolizumab plus chemotherapy, atezolizumab alone, or chemotherapy alone. This looked like, again, this was not yet statistically significant, but certainly a trend looking like the combination was potentially better than the chemotherapy alone. The overall endpoint of this trial is looking to see if people live longer with the combination, so we still have to wait some period of time to find that out. But one of the important things too was looking at whether or not tumors had this target called PD-1 or PD-L1 on the tumor cells. And what we could see is that when PD-L1 was high, and that means IC, it's called 2 or 3, that atezolizumab seemed to be a very reasonable treatment, meaning on these what's called Kaplan-Meier survival curves, that patients who had atezolizumab alone seemed to do better, at least in the long term, compared to those who got chemotherapy. This was not necessarily true if that target called PD-L1 was not present. So this in part helps us decide what's the best treatment for patients when they are first diagnosed with an advanced urothelial cancer. And so we still don't know whether or not in the future we're going to be combining or only sequencing chemotherapy with immunotherapy when patients are first diagnosed. This is an exciting trial that is opening actually across the world. It's an international clinical trial looking at a very attractive combination. So this is a drug called pembrolizumab, again, FDA approved, and it combined with enfortumab. So both of these drugs are FDA approved for urothelial cancer, but in terms of combination, not yet approved. And what we saw, what was seen, because we did not participate in this trial, but in patients that were treated with this combination of treatments, when they were not eligible to receive platinum-based chemotherapy, again, you're learning all about these waterfall plots, had a really tremendous control of their tumor shrinkage for the most part, or disease control if they wound up above this line. And this was regardless of expression of PD-L1. And also we know that in this group of patients that may have hearing challenges or renal insufficiency or other kind of issues that preclude them from being treated with cisplatin, that they can be treated with this combination. And so currently we have this combination clinical trial open, a large phase 3 trial looking at randomizing patients to receive this novel combination compared to the standard of care. So in terms of targeted therapy, there's other targets that are under investigation here at Hopkins and elsewhere. There's a well-known target that is active in not just urothelial cancer, but in kidney cancer as well, called mTOR. There's a target in breast cancer called HER2 that's very active, that we know can be active in urothelial cancer. There's changes called DNA damage or response alterations that can render tumors very responsive to certain treatments, including a drug called olaparib, a PARP inhibitor that's FDA approved for ovarian cancer that we're using in patients that have urothelial cancer. And this target called TROP2. TROP2 is the target for another antibody drug conjugate, which is currently FDA approved for bladder cancer. And I believe is now currently in front of the FDA, potentially to, again, expand the indication for use in urothelial cancer, because it seems very active for our patients as well. So in summary, new FDA approvals for advanced urothelial cancer. There have been 7 new agents for 5 separate disease states. Cisplatin, which is a challenging chemotherapy, remains our backbone standard of care. Checkpoint inhibitor data looks like right now the standard of care is in sequence, but potentially in combination. Enfortumab is active in patients that have hepatic metastasis, which is liver metastasis, something I didn't mention previously. And we're really, I think, starting to think of ourselves as splitting urothelial cancer patients into different populations based on response and resistance to certain drugs, as well as alterations and changes that may lend those tumors more to response to therapy. I think given time, I'm gonna leave that as my potential last slide. And go back to my thank you slide and take some questions if there are any. And I thank you for your attention. I know I went pretty fast.
Hello, everyone. I'm back again. So, recognizing the unique needs of women with bladder cancer, look for information on a new support group focused on women with bladder cancer. Doctors Hoffman-Censits and Armin Smith will be hosting this Zoom session on December 1st from 4 to 5:30. Any questions, please put them in the chat or in the question and answer box. So I don't see any yet. Maybe I'll open the floor with the first one. So Jeannie, what is your favorite clinical trial?
Oh my gosh, that's a really hard question to answer.
That's why I asked it, yes.
I think I don't necessarily have a favorite clinical trial. I think there's nothing that Dr. Hahn or I don't bring to the table to discuss or don't bring to our IRB and our group to put in front of patients that we don't wholeheartedly believe in. And so each clinical trial for each disease state is different. Some of them, you know, we have designed and developed over the period of, you know, months or years, and in some cases many, many years. And those are, you know, ones that are kind of near and dear to our heart. They may or may not change standard of care. They may just help us really understand the disease better. And then there's other kind of large ones that, you know, if it winds up being positive, if a new treatment is better and less toxic than our current standard, then really everything changes. So that is also very kind of exciting in a different way. But I can wholeheartedly say that there's nothing that I would offer to a patient that I don't, like I said, wholeheartedly believe that this is an important trial to do.
So here's a question from Karen Sachs. So are the same trials run out of Sibley?
That's a great question. For the most part, we're working to build up our clinical trial portfolio at Sibley. There's certain clinical trials that have these very specific what's called correlative studies. So when we do a clinical trial and we give a drug to a patient or a population of patients, we don't just want to see how it works. We want to understand why it works or why it doesn't work or why certain patients have certain toxicities. And in order to do that, we have to collect a lot of samples. So potentially normal tissues, biopsies, blood samples, urine samples, and over a long period of time. And for some of those trials, we have to process them in very specific ways. So sometimes that happens in smaller clinical trials. We're really starting to learn more about a certain pathway. And when that's the case, institutions like Hopkins in East Baltimore may be the best suited location for that, with specialized teams that are able to handle those samples in real time for time-sensitive tests. But for other clinical trials, we can ship samples, or we can, you know, extrapolate other kinds of data, or wait for a certain trial to get beyond a point. So many of our trials, although not all of them, are open at Sibley.
Thank you. Other questions? So if not, I'll ask one more. So this is kind of a high-level question again. Should we be redirecting some of our attention away from immunotherapy trials toward other targets, or do you think the balance we have right now is about right?
No, I mean, immunotherapy is incredibly exciting, and I think that, you know, thinking about expanding the indication, right now immunotherapy is FDA approved for urothelial cancer that's untreated in patients that have tumors that are PD-L1 high or overexpressing that target, or who cannot get chemotherapy at all, for patients with progression of their disease on standard therapy, and for a certain cohort of patients that have BCG refractory non-muscle invasive bladder cancer. The interest in immunotherapy, and I think so many patients kind of come to us asking, well, can I get immunotherapy, is because of what they've heard about it. You know, it does tend to have low toxicity, although in some patients that's not the case. It can have this very durable benefit. So really, I think understanding why it works in some patients, why it doesn't work in others, and thinking about how to rationally combine it with other treatments, whether or not that be other immunotherapies or other targets, to help activate the immune system, particularly for patients where maybe they got an immunotherapy, didn't have any side effects from it, but also didn't have any response. So that's a group of patients that we are very kind of interested in looking for other immunotherapy clinical trials where their immune system may eventually become active.
Thanks. I think you just answered Saul Dunn's question. So there are new work investigating whether a late stage therapy using against more invasive cancers being used in less invasive cancers. I think you basically gave us the example of immune checkpoint blockade moving forward in the disease states, the point now where it's BCG unresponsive disease, and now Noah Hahn is putting it even earlier than that in the DAP bladder trial. Are there places where we can see evidence for erdafitinib or enfortumab vedotin moving into those same disease states?
And that's the dogma of clinical trials, right? So medications are developed often in the late stage of a disease where there is no current standard of care. And then kind of really understanding the disease, the treatment in that setting then leads us to rationally design clinical trials where a treatment can move earlier and earlier. So in fact, you know, I talked about 2 clinical trials in the adjuvant or postoperative space to decrease the risk of a cancer coming back if it did not melt away, it wasn't annihilated with first-line therapy. So absolutely, you know, oftentimes those trials can be somewhat more challenging to do, just based on the nature of those earlier stage cancers.
And I think I saw a question come in and then go away. Do we know how long to treat patients with these new immune checkpoint blockade agents?
That's a really, really, really good question. And the answer is no, not really. I think we learn by doing, and we learn from treating patients in clinical trials. A lot of immune therapy clinical trials didn't, when they were designed, didn't necessarily have an end date. And in part that was based on, which is actually a good thing, and in part was based on the landscape where they were developed. If, you know, if you think of if a patient had no other option other than ineffective single agent chemotherapy after cisplatin, and they were allowed to go on an immune checkpoint blockade therapy and had great response to it, you would hope that clinical trial would not have an end. So it's good for patients, and I have patients, you know, from my prior practice when I practiced in Philadelphia, still on clinical trials, you know, from those initial studies. But we don't know whether or not stopping the treatment, potentially limiting toxicity, certainly making it a less costly therapy, would give you the same outcome. We're learning some of this from other diseases like in lung cancer where they've started to do these trials, but sometimes it's really just based on an individual who either decides to stop therapy or has to pause therapy because of a toxicity.
Thank you. So I think we're going to wrap up. I just wanted to confirm that Jeannie and I do have our masks and wear them whenever we go outside of our offices.
Got an Orioles mask today.
Hopkins policy. I've got my Brady mask here. And we're looking forward to hosting you all to our remaining sessions, November 17th with Trinity Bevilacqua on staging and standards of care, and December 15th with Phil Perazio talking again about upper tract urothelial cancer. We're always here for you. Reach out. bladdercancer@jhmi.edu. And again, Jeannie, thanks very much for this wonderful talk. And we look forward to seeing all of you again next time. Goodbye, everyone.
Thanks for having me.